Hello students, today I'll talk about the macromineral phosphorus. Total body phosphate is about 600 grams to 1 kg. 80% is found in bones and teeth. 10% is present in soft tissues like muscles. Remaining 10% is widely distributed in various chemical compounds. Sources of phosphorus are milk and milk products like cheese, cereals like wheat, maize, oatmeal, nuts, leafy vegetables, meat, salmon, eggs, etc. Daily requirement of phosphorus is 500 mg per day. Absorption of phosphorus. Phosphate is absorbed as inorganic phosphate from metal jejunum. Calcitriol or vitamin D and parathormone promotes uptake of phosphorus along with calcium. Absorption is optimum when dietary calcium is to phosphate ratio is between 1:2 to 2:1. Acidity favors, while phytate decreases phosphorus uptake by intestinal cells. Bile salts help in absorption by including calcium phosphates in water-soluble micelles in the intestinal lumen. Fatty acids during fat malabsorption reduce its absorption by forming insoluble compounds. Iron reduces its absorption by forming insoluble ferric phosphates. Distribution of phosphorus. Phosphate is mainly intracellular ion. In serum, phosphorus concentration is 3 to 4 mg per deciliter in adults and 5 to 6 mg per deciliter in children. Serum phosphate may be 55% free ions, 35% constitute complex form with cations such as calcium, magnesium, sodium, and potassium, and 10% is bound with proteins. Whole blood contains 40 mg per deciliter of phosphorus. RBCs and WBCs contain a lot of phosphates. Organic phosphate esters are located primarily within the cellular elements of blood. Hemolysis should be prevented when blood is taken for phosphate estimation. Plasma contains both inorganic and organic phosphate. Organic phosphates include lipid phosphorus like phospholipids and phosphoesters like ATP and hexose phosphates. Inorganic phosphate exists as both monovalent and divalent phosphate anions. Inorganic phosphate is a major component of hydroxyapatite in bone. Excretion of phosphorus. 0.8 to 1.4 gram of phosphate is excreted in urine daily. 70% of the filtered phosphate is reabsorbed in tubules. Renal threshold is 2 mg per deciliter. Urinary phosphate excretion is influenced by factors like muscle mass, renal function, and age. A diurnal variation in urine phosphate excretion has been noted, with the highest output occurring in the afternoon. Functions of phosphorus. It is an important constituent of bones and teeth. It is a component of phosphoproteins, phospholipids, lipoproteins, and nucleic acid. It has a role in energy transduction. Energy produced by metabolic reactions is stored as high-energy phosphate bonds of ATP, creatine phosphate, etc., and is utilized in driving endergonic processes. Acid phosphate buffer. Mixtures of hydrogen phosphate and dihydrogen phosphate constitute the phosphate buffer of body fluids. Role in phosphorylation and phosphorylasis. Phosphorylations are essential reactions in many metabolic pathways. Phosphorolysis is the cleavage of a covalent bond by phosphoric acid, for example, phosphorylasis of glycogen to glucose 1-phosphate in glycogenolysis. Role in enzyme action. Phosphorus is a component of nucleotides functioning as coenzymes and phosphatic groups like NAD, NADP, PLP, TPP, FMN, FAD, etc. Enzymes such as glycogen phosphorylase, glycogen synthase, etc. are modulated by reversible phosphorylation and dephosphorylation, also known as covalent modification. Other functions of phosphorus are formation of phosphate esters such as glucose 6-phosphate, phospholipids, etc. Formation of phosphoproteins like casein. In DNA and RNA, phosphodiester linkages form the backbone of the structure. Regulation of phosphorus. It is similar to calcium regulation. Phosphorus is regulated mainly by kidney. Vitamin D enhances phosphate reabsorption in renal tubules. Parathormone increases intestinal absorption of phosphorus, enhances phosphorus mobilization from bone, but decreases phosphate reabsorption by renal tubules. Calcitonin lowers serum inorganic phosphate by decreasing phosphate mobilization from bones and by decreasing its reabsorption in renal tubules. Hyperphosphatemia, that is increased phosphate in blood, occurs when there is increased absorption of phosphate in excess vitamin D and excessive phosphate infusion. When there is increased cell lysis during chemotherapy for cancer, bone secondaries, and rhabdomyolysis. Hyperphosphatemia also occurs when there is decreased excretion of phosphorus in renal impairment and hypothyroidism, during hypocalcemia, in massive blood transfusions, in thyrotoxicosis, or in administration of drugs like chlorothiazide, nifedipine, furosemide, etc. Phosphatemia or decreased phosphate in blood occurs when there is decreased absorption of phosphate in malnutrition, malabsorption, chronic diarrhea, vitamin D deficiency, when there is intercellular shift like insulin therapy, glucose phosphorylation, respiratory alkalosis, etc., when there is increased urinary excretion of phosphate in hyperparathyroidism, Fanconi syndrome, hypophosphatemic rickets, in hereditary hypophosphatemia, in hypercalcemia, in chronic alcoholism, and in administration of drugs like antacids, diuretics, salicylate, etc. Differential diagnosis in different combinations of serum calcium and phosphate levels. Phosphate is increased and calcium is decreased when there is hypoparathyroidism, renal disease. Increased phosphate with normal or increased calcium is seen in milk alkali syndrome and hypervitaminosis D. Decreased phosphate with increased calcium is seen in hyperparathyroidism and sarcoidosis. Decreased phosphate and calcium is seen in malabsorption, vitamin D deficiency, and renal tubular acidosis. Phosphorus, thank you.